Thank you all for inviting me here. So I graduated from the program in 2022 officially, and my thesis, I focused primarily on adolescent cancer patients and addiction potential. Currently, I'm a social worker at an oncology clinic here in Athens, Georgia, working towards my clinical licensure. And I have been a medical social worker all my life, which is how I really came to understand bioethics. Um, I also, on a personal note, am a 3-time adolescent cancer survivor, and I am in active recovery. So all of the questions that I asked for my thesis were really born out of personal experience. So this is just an overview of kind of what I'm going to talk about, and it is just in light of the national narcotics crisis, adolescents and cancer treatment may be at a heightened risk for addiction development because we are working with incredibly powerful narcotics to control pain. And it is ethical to control the pain, but it is also ethical to try to reduce the risk of addiction and causing further harm to our patients. So it's really interesting because the medical field has identified the AYA, or the adolescent and young adult cancer care gap. So lower participation in clinical trials, less research into the AYA population, problems with care transitions, which has ultimately led to a lot of programming for the AYA age group, which is usually 15 to 39. Your adolescent age range is usually going to be between like 14 to 18, depending on which recommendation you go with. Some say up to 25 when the prefrontal cortex stops developing. For the purposes of my thesis, I went with 15 to 18, which is the age of majority in most of the states in the United States. But a lot of programming has come around to address the specific needs of AYA patients. This comes out of Sloan Kettering. You see this at UCLA. Emory has a program. But despite the fact that there are a ton of resources out there and a ton of programming to address a myriad of specific and unique needs for adolescent and young adults who are either in treatment or in survivorship, addiction is not one of them. Despite the fact that we have a decades-long opioid crisis, and the unique vulnerabilities of the AYA community, specifically adolescents. So that's what I focused on. So my questions were, why haven't we focused on addiction in adolescent oncology? Why are adolescents specifically vulnerable? What do physicians, what do care teams who are treating adolescent patients owe them once the treatment is over? And then what could be done about it? My proposed answers, it was a lot, and it's hard to evaluate what an answer would look like. But the reason I feel like we do not discuss addiction in adolescent cancer patients is what I will call cancer exceptionalism, which is the idea that physicians worry less about addiction development during treatment because of the legitimacy of cancer pain. So because the best thing to do and the frontline treatment for cancer pain is narcotics, and controlling that pain is one of the most paramount goals in cancer care, and because of the legitimacy of cancer pain, doctors are less likely to be concerned in adolescents about addiction development. And you do see this in research. You see that doctors will say, well, we're not worried about that. We're worried about making sure that they're not in pain. We're worried about treating the cancer. Their kids, this isn't something, we're going to have to worry about because we're watching them, we're prescribing. But a research study out of Emory, actually, at Children's Healthcare of Atlanta, with Dr. Zhuzhai, said that adolescent cancer patients are actually 59% more likely to misuse prescription opioids and 67% more likely to have a prescription drug use disorder than adolescents without a cancer history. So it's definitely not something that we can afford to ignore. And this is also seen on the policy level with pain guidelines for cancer kind of being carved out of those and differentiated and being much more vague than those that are made for like chronic cancer or acute surgical, chronic pain or acute surgical pain after, say, an ortho surgery. So you have this kind of overarching idea of, okay, we're not as worried about it. Well, why are adolescents specifically vulnerable? Well, the first is going to be their brain development, specifically the underdevelopment of the limbic system and the prefrontal cortex, which affects how they are perceiving their world and how they are examining their risks. Secondarily, we're going to be looking at their lack of autonomy. Pediatric care is primarily paternalistic, so you get talked around a lot in pediatric cancer care. And ultimately the decision is not yours. And adolescents aren't taught or encouraged to talk about what addiction to a narcotic looks like, how that feels, so they don't have the words to put it out there. And a parent's primary goal is the comfort of their child. So they're going to encourage pain management. Then we have the psychological trauma of a young cancer diagnosis, as well as the lack of appropriate supports moving into survivorship, specifically with care transitions and going from a pediatric model to an adult model of medical care. So what do we do? What do we owe these people? We owe them not to bring them extra harm. If we're going to treat them, we have to make sure that we are not bringing extra harm, even if we are curing the cancer. With me, it was very much a situation of, yay, your cancer is cured, go out, live. But now I'm dealing with a lifelong opioid addiction. So my solution was to push the incorporation of addiction professionals into oncology, more research into challenging and addressing the idea of cancer exceptionalism, and really honing in on these harm reduction strategies that we have for addiction medicine, and how can we make them work in both pediatric and young adult settings. So yeah, that was the quick and dirty of all of that. And a special thank you to David for dealing with my anxiety and supporting me and believing in my research.